Let's take a look at the cardiac medications, and this is part 2, and we're probably going to have part 3 and part 4. So let's start out talking about why we're using these particular medications, and what we're talking about today is the treatment of myocardial ischemia and pain. So if you remember, when we have myocardial ischemia, that's on the very outside before we get into the deep injury and infarct. So it occurs almost immediately after the loss of blood supply. Remember that the tissue can still depolarize, but ischemia affects repolarization. So what we typically see is ST segment depression and an inversion of the T wave. So when you see the ST depression here, as in this horizontal, greater than a millimeter low, there's a very low error rate when you see that. So you kind of know that you've got definite ischemia going on there. So they're just showing you here the different types with the AHA criteria. So again, can be reversed if treated early. So that's the key to the whole issue of ischemia and why we try to treat myocardial ischemia and pain quickly. So let's talk gas. Again, don't forget that oxygen is a drug. What it does is it increases the O2 content of the blood, and it also helps to oxygenate those peripheral tissues. We also have nitrous oxide, which basically is just an analgesic. That's the kind of laughing gas that we see very often in the movies and such. It's not anything that typically is carried here, but again, you need to know it because it is part of the curriculum. Again, it's used as an analgesic, and that means it helps in the relief of pain. Now, it can also be used with O2, and if it's combined with 50% oxygen, it can increase myocardial oxygen supply. So it's actually very good to use if it's something that a service carries. Let's talk about nitroglycerin. Now, nitroglycerin is one of those things that you'll be seeing a lot of, giving a lot of, those types of things, but knowing why it works, how it works is really very important. One of the things that you'll notice is NTG is very often used as the abbreviation for nitroglycerin. It's a vasodilator. It works on smooth muscle tissue. It's a smooth muscle relaxant. It works on vasculature, works on bronchial muscle, works on uterine muscle, and it also works on intestinal smooth muscle. So that's that whole issue of the smooth muscle effects. It also reduces preload and afterload, and what that's going to do is that is going to decrease the workload of the heart. Really, really important if we're talking about ischemia and trying to get that stopped before it heads into injury. And what that does is it reduces that myocardial oxygen demand. So all of that helping to stop the process before it gets into the injury phase. So what do we use it for? Well, we use it for ischemic chest pain, we use it for angina, hypertension, CHF, and you'll learn about that later, and also for pulmonary edema. How do we get it? Well, it comes in pills, and I'm sure most of you are familiar with seeing the small brown pill bottles. As soon as you open that vial, it starts to degrade. So very important that it's kept. That's why it's kept in the dark pill bottle. Those types of things, it starts to lose its effectiveness. So it also comes in paste and also comes in spray. And again, we have a 0.4 milligram for our tablets and a maximum of 3 doses. Spray, again, 0.4 milligrams, maximum of 3 sprays in 15 minutes. And the paste goes on in inches. And you'll notice on the patch here, the NitroBid patch, you'll see that you actually apply the paste, and there's your ½ inch, there's your inch and a half, your 2 inches. Typically, it's 1/2 to 3/4 of an inch, which would be 15 to 30 milligrams. Maximum there is 5 inches per application. Really important thing when you're working with either the spray or the paste. Be sure that when you do that spray, you are not inhaling any of it, because one of the things that happens is you have a very sharp decrease in blood pressure. So, again, we're working on getting all of those things down, and you can have an event by having that happen. When you're working with the paste, gloves, do not get this on your bare skin. If you do, you're going to have the same side effects as your patient. So you don't want to be passing out in the back of the ambulance when you're working with them. So remember, try to keep your face away from the spray, and make sure that you have gloves on when you're using the nitrobid paste. Okay, what are the contraindications? Again, we need to know, we know what we're using it for. When don't we use it? Well, if someone is already hypotensive, you're not going to give them nitroglycerin, because you're going to drop that blood pressure really, really low. Anybody that's hypovolemic, you're not going to use nitro. Also, head-injured patients, don't go there with that. Severe bradycardia or tachycardia, we do not use nitroglycerin in those cases either. The other thing you need to make sure that you check is if the patient has been using any of the erectile dysfunction medications. You cannot use it within 24 hours when you're doing your Viagra or Levitra. If it's Cialis, it's within 48 hours. So you want to make sure that you check that, and be sure that you're not only checking with male patients, that can also be female patients as well. Morphine is another drug that's used when we're talking about myocardial ischemia and pain. And morphine basically is an opioid analgesic, and you should remember that from last semester. It is working on those opiate receptors to help relieve pain. It's also a Schedule II narcotic drug. So how does it work? It reduces myocardial oxygen demand, again, reduces preload and afterload. Another thing it does is it works on the central nervous system to relieve pain. So another reason why we're using it with myocardial ischemia and pain actually works on two different things that's going on there. What's our dosage? Well, it's 3 to 5 milligrams, slow IV push. And I cannot stress that enough. This is a slow push. You don't want to just pop 5 milligrams into a patient. It is extremely uncomfortable, and you're going to make them very woozy and drop that pressure way faster than you want to. Again, these are the kind of things that you want to make sure that you have an IV started and you have fluid available in case you need it. Again, monitor that blood pressure before you give it. So again, you're not going to give it to anyone that is hypotensive. You're not going to give it to anyone with a head injury, depressed respiratory drive, any undiagnosed abdominal pain. You don't use morphine for. So again, abdominal pain is not necessarily what we're talking about here, but you don't want to use it in those cases. If you've got a decreased level of consciousness, you don't want to use morphine. If you suspect any kind of hypovolemia, so again, those are reasons that you would not want to use it. Make sure that you take a look at your side effects. You're going to have confusion, sedation, headache, central nervous system depression, respiratory depression. So you've got to be ready to treat these things if they happen. Fentanyl is another drug that is becoming more and more popular in the pre-hospital environment. And basically what that is, it's a synthetic drug, and it's an opiate analgesic. So it isn't, normally occurring. It's something that's made up. Again, it is also a Schedule II narcotic. Analgesic, reduces pain. It's much shorter acting than morphine, and it has a better side effect profile, which is why we're kind of using it a little bit more often. Contraindications for this one is pretty much a known hypersensitivity and used very cautiously with traumatic brain injury. Side effects can be confusion, delirium, drowsiness, central nervous system depression, sedation, respiratory depression. Again, all of those types of things that we would see in using any opioid analgesic. You have to be careful if you're using other central nervous system depressants. So if you're getting morphine and fentanyl, you're going to have some issues. I had an issue with somebody with an overdose, an elderly patient that had fentanyl patches on and was also getting morphine, and they ended up, with respiratory depression and those types of things. Dosage and administration, we are typically giving this IV. It can also be given intranasally if you need to. Onset is immediate when it's given via IV, and the dose is typically 50 to 100 micrograms in the adult patient. So it's 1 mic per kilo. It's, again, a slow IV push, and when it says slow IV push, they mean it. So make sure that you are aware of that, and you're usually giving it over 1 to 2 minutes. So that would be your slow IV push for this one. And finally, aspirin. Again, the abbreviation that you'll see very often for this one is ASA. And what this does is pretty much it prevents platelets from clumping up together or aggregating and forming any kind of emboli. So very useful when we're talking about myocardial ischemia and working with an MI patient. Pretty much contraindications would be hypersensitivity to it, and also this is never, ever, ever used in pediatric patients because of Ray's syndrome. I personally know a youngster, 4th grader, who died, who was given aspirin, and that was back before the whole Tylenol thing became fashionable, was a student in the school that I taught in. So it does happen, and again, is not used ever in pediatric patients. If you have patients that are allergic to NSAIDs or nonsteroidal anti-inflammatory drugs, you would use aspirin cautiously there. Usually we have 81 milligram tablets, the baby aspirins, and we give 4. Chewable is the preferred way to do this. You don't want them to swallow it. So again, those are a couple of the drugs we're using to treat myocardial ischemia and pain, and look forward to part 3.